Okay. So we're about 6 minutes after 7. So I'm just going to share the results with everybody. So about half of our attendees are from long-term care or retirement. We have 33% in home and community care, and 11% students. We have nurses that have worked for 2 or less years, 5 to 10, with the majority being between over 10 to 20 years. We have PIECES training for less than 5 years, less than 10 years, and some participants that have not had PIECES training. So after the presentation today, you'll have an opportunity to ask our speakers some questions and learn more about their work with PIECES. You're welcome, everybody. Okay, so I think we'll get started here. I'll just start off by welcoming everybody to our RPN quarterly research webinar titled Experience of, sorry, let me share this. That way you can see the title. So experiences of RPN champions in virtual team care planning and long-term care using PIECES research project. Tonight, we will be hearing about the Healthcare Excellence of Canada funded research study and how the experience of 3 RPNs who serve or served as RPN champions in the research study enhance the study design and findings. Please submit any questions in the Q&A or chat section of Zoom, found in the toolbar at the bottom of your screen, and we will have time for discussions and for your questions to be answered throughout the presentation. I'll now ask Annette Weirs, Senior Director of Professional Practice and Research at WeRPN, to begin our evening.
Hi, everyone. Thank you for coming and joining us for this wonderful session. In tonight's session, as Jen said, you're going to hear about the experiences of our 3 RPN champions in 2 long-term care homes who were involved in a research study that focused on a clinical practice implementation to improve team-based care planning in long-term care. Using video, remote, and instrumentation, the PIECES framework, and trained point-of-care RPN leaders, the presenters will describe the impact of 3 promising practices to prepare for future pandemics, enhancing caregiver engagement and leadership support for the workforce. So I'm going to begin by introducing our speakers for the evening. I'm going to begin with Jacqueline. If you could just give a little wave there. Thank you, Jacqueline. Jacqueline Ripley graduated from the PN program at St. Clair College in 2018 and began her career as an RPN at Copper Terrace in Chatham, Ontario in 2019. And in 2021, Jacqueline was promoted to the management team on an interim basis to assist during the pandemic. Since then, Jacqueline has become an IPAC specialist, she was invited to take part in this Healthcare Excellence Canada research project as a PIECES champion. Our next presenter is Deb Lernout-Banks. There's Deb. She has been an RPN at Copper Terrace long-term care home for 16 years, and recently she transitioned in the role of Behavioural Support Ontario internal RPN champion after several years working as a staff member providing direct care for residents. Deb has attended multiple webinars, workshops, and nursing education opportunities, including U-First, GPA, dementability methods, and PIECES. And Deb became recertified in PIECES in 2022 and is very excited to have been part of this research process. And our final speaker for tonight is Melissa. Melissa Postel Babcock is a registered practical nurse, and she works at Vision Nursing Home in Sarnia, Ontario, and she's been there for the past 20 years. She graduated with a PN diploma from Lambton College in 2005, and over the years, she has worn many different nursing hats, including frontline care, BSO, internal champion, MDS RI coordinator, point-click care configuration, and most recently, quality improvement coordinator. Melissa's career has focused on working with the geriatric population in long-term care, and she is passionate about providing client-centered care and improving the quality of life for residents. And finally, Nancy Snobelin. Nancy is our amazing research consultant at WeRPN, and she holds a Doctor of Health Administration, a Master of Business Administration, and a Bachelor of Science in Communication Disorders. She serves as the WeRPN liaison. She served as the WeRPN liaison on this exciting research team. And Nancy is going to begin by introducing the research study. So I'll turn it over to our panel.
Thanks, Annette. As I introduce the agenda for this evening's webinar, I will acknowledge our funding partners. You'll hear about the clinical challenge that sparked this opportunity for this clinical practice implementation science research. You'll hear that the RPN's champion can discuss the process of being educated and mentored virtually on the PIECES intervention and then implementing the intervention and its impact. And then you'll have the opportunity to ask questions and discuss next steps with the research team. So next slide. So we acknowledge the sponsors mainly being the Healthcare Excellence Canada and their partners, and also WeRPN, PIECES Canada, Vision 74 Long-Term Care, and Appens Copper Terrace Long-Term Care. Next slide, please. So COVID resulted in profound loss of life among older adults living in long-term care. And as a result, long-term care homes were subject to intensified infection control practices, such as isolating older adults in their rooms and canceling therapeutic programs, communal gatherings, and restricting family members' face-to-face visits. Social isolation negatively impacts the psychological and physical health of the older adult, with symptoms of anxiety, depression, physical and cognitive decline, disorientation, fear, apathy, and premature death. It also can increase expressive behaviors. 51% of family members from long-term care reported an increase in behaviors and a subsequent increase in the use of antipsychotic medications. Residents and families were not the only people who suffered. RPNs and other healthcare workers in long-term care also experienced moral distress, fear, anxiety, depression, and financial loss, creating the need for a presence of personal, professional, and organizational resilience. This resilience in RPNs was studied in partnership with Western University and WeRPN through a Social Sciences and Humanities research grant. Self-care resources and organizational resilience resources were established through this first grant. And then clinical practice resources were also required. So leading to our opportunity for implementing interventions to support older adults and the care staff and call attention to the need to engage all persons caring for them in team-based care planning processes and policy development. Next slide. The research application was based on Reimagining Long-Term Care. It was a report that identified 6 promising practices and then the subsequent studies. So the 2 grants, Long-Term Care Plus, Acting on Pandemic Learning Together, and Implementation Science Teams, Strengthening Pandemic Preparedness in Long-Term Care. Our team chose to work on 3 practices to mitigate, as Annette said earlier, the people in the workforce, the planning for COVID and non-COVID care, and the presence of family. Our previous work allowed us to field test it, the clinical practice and leadership enhancement interventions that would serve to further COVID plan and non-COVID plan. Next slide. For those of you who are not totally aware, PIECES is a team-based care planning model with relationships at the core to address collaborative assessments and shared care design for interdisciplinary teams to address complex physical and mental health, cognitive, emotional, social, and psychological needs of older adults. PIECES stands for physical, intellectual, emotional health, maximizing capabilities to support quality of life, integrating the living environment of a person, and encompassing a person's self, including beliefs, culture, and life story. That's what this is the intervention that the RPNs were educated on. And now you'll hear the actual experiences of these 3 RPN research champions. So I'll pass it to Jackie.
Thank you, Nancy. Copper Terrace is a 4-unit long-term care home. At capacity, we have 132 residents here. The research team from Copper Terrace included myself, the IPAC lead, along with the Pieces Champion lead for the home, and Shannon Snellgrove, our executive director, along with 7 RPNs who received Pieces training via a virtual format due to COVID. Although we did have some trial and error and many revisions during the initiation of processes to find what works for our home, we were able to successfully incorporate Pieces into our practices here. The process we found that worked best for Copper Terrace was having 1 or 2 RPN Pieces trained come out of staffing for 2 days. Typically, we scheduled the days off the floor about a week apart. The first day has been to review and complete referrals, review the residence chart, investigate what some triggers may be, brainstorm some questions that would be beneficial to ask the resident or family. During the first day, the RPN would also reach out to the family to set up the time for the following week where they could have a meeting. We encouraged Zoom calls as often as possible, but also did offer telephone calls if that worked better. The focus of this research was to be able to utilize the Pieces tools that we learned to support older adults living in long-term care homes who were experiencing behavioral expressions during COVID-19. The pandemic was a very trying time for all, and the healthcare industry especially had a spotlight on them with increased restrictions. During the pandemic, visitors for residents were restricted to reduce the spread of COVID-19. We did offer ways of communication to be able to learn more about the resident we were focused on. However, after the first couple of weeks of telephone calls and Zoom calls, we discovered that a Zoom call was much more effective. Being able to see the other person's expressions, enabling the resident to see their family member even via Zoom, was better than a phone call. The residents and families were able to bounce different ideas, memories off of each other. They seen pets that they hadn't seen in quite some time. We quickly realized how much of a benefit the video call was and began encouraging Zoom calls more than phone calls for this reason. The RPNs would then summarize the interventions, write a progress note, and complete health teaching with the primary staff on the unit. We also created a Pieces binder for each unit. This way, the interventions recommendations were able to be effectively communicated to all staff. Initially, the 7 RPNs that were Pieces trained did not realize that there was going to be more than just being Pieces trained. I'm unsure if this was a lack of communication or explanation from us as we asked the RPNs to participate in taking the course. But after being Pieces trained, we initially wanted to pull staff off the floor. However, the RPNs were not interested in this. We then revised the process and attempted to implement the Pieces process as part of their routine while working, but this was just not achievable. We found the Pieces referrals were not being completed due to time constraints and prioritizing their cares on the floor. We then went back to our original process of alleviating staff from the floor for a couple days to be able to work through the process. Although we had quite a few of the Pieces trained RPNs not wanting to try this at first, we did have 2 RPNs that were excited about being able to participate. After a few weeks of working through the referrals, their excitement grew as they felt that they were really getting to know the residents that they care for on a more personal level, along with finding great interventions that families suggested or the RPNs may have come up with based on the research they did into this resident's pre-admission history, speaking with the family and the residents themselves, along with coworkers. The RPNs also shared their knowledge and interventions to try with the unit staff. I believe this is what prompted 4 other Pieces trained RPNs to get more involved and were willing to try the referral process. For our home, we did have an internal BSO team who assists with behaviors, so we felt it was necessary to make a refer to who list. Basically, we decided if it was immediate interventions that were needed, the staff should refer to the BSO team, and if it was ongoing, non-urgent, or no risk to harm, a referral could also be sent to the Pieces team. This was decided since the BSO team consists of 1 RPN and 1 PSW, whose roles are dealing with the behaviors throughout the home, and are available 7 days a week, whereas the Pieces team is maybe once a week if we are able to staff it and have enough referrals to be completed at a time. We aimed for 4 or 5 referrals to be an effective shift off of the unit. We did have some difficulty at times being able to replace staff in order to pull the pieces trained RPNs off the floor for the referrals, especially during outbreaks. It was extremely hard during outbreaks since not only residents are sick, but also many staff end up sick and off work as well. However, this would have been the most beneficial time for the pieces team to be most active, as we often see elevated behaviors associated with being isolated for long periods of time during outbreaks. This was the first time I have ever been part of a research team. I personally am a very hands-on person, so in the beginning of the research project, it was more about the logistics, data collection, funding, and such. I found it hard to grasp onto what everyone was talking about at times, but I did enjoy learning. And so being able to do the pieces training was great. However, I found I became a lot more interested when we began the process in-house as I took part in doing referrals. Reading a resident's history, coming up with questions to ask the resident and their family, it was an amazing feeling to watch it play out and be effective when we came up with interventions that worked. I have since took a bit of a step back, and we have transferred over the lead of pieces to our internal BSO lead, as our pieces referral goes hand in hand. Our internal BSO RPN has a bit more time to be able to focus and suggest interventions, since this is what she does daily. I will let Deb talk about that process.
Thank you, Jackie, for that conversation. When I first started the Pieces project, I was initially working in the frontline nursing role and wasn't one of the frontline nurses that were involved in the research project. I did complete nurse Pieces training previously and had not known the extent of the project at the time, but was glad my co-nurses were going to have a chance to receive the Pieces education. As the project continued, I did learn more about the project and what was happening from discussions that I had with my co-nurses. I was generally a curious person who does enjoy learning new things, so I found their experiences very interesting. However, I had only known a little bit about the project. I wasn't able to know the full extent as I was working on the floor, and I just gathered a little bit from general casual conversations. In 2022, I transitioned to the role as the Internal Behavioral Supports Ontario champion at Copper Terrace. When I transitioned, I had the opportunity to engage with members of the research study via Zoom and in person. I learned about what the goals, processes, challenges, and outcomes that have been achieved prior to my involvement and what we were looking to achieve further. I took the time to have further discussions with the RPN leaders who had been involved in the processes and learned a lot more about what their contributions were to the project. I was also able to review the Pieces team referral process documentation, what they had incorporated, and what sample scripts they had developed when they reached out to families. After learning about what the project was involved, I was able to arrange with my management team a day where one of the members of the RPN frontline leads were able to be replaced off of their unit for the day to provide me training on the Pieces team referral processes. During this time, the RPN showed me how the Pieces referrals were completed and how to conduct the virtual components of the research with the families, residents, and staff using the Zoom platform. She provided me tips on what worked and what didn't work when completing the Pieces referrals and during the interactions with families. I could clearly observe how much she enjoyed being part of the project and how it had given her a chance to momentarily pull back from her routine day-to-day interactions, allowing her to discover more about the residents she was caring for. She presented ideas to me about what she thought she would be able to trial with frontline staff to increase their engagement with the residents and how to direct undesirable behaviors they were presenting and rule out things such as urinary tract infections or other infections that might be causes of these changes in behaviors. Next slide, please. After completing the training sessions with the one of the Pieces RPN leads, I began to consider how these processes could function alongside my role as an internal BSO champion. Having the Pieces team referral processes in addition to my BSO referrals allowed frontline staff to learn more about their patients, encourage them to engage in conversations with families, residents, and other possible interventions and strategies. They were able to engage in conversations that involved all of these members, even if they were outside of the local area. We currently do have family members that are outside of the province of Ontario, as well as some parts of the US, and in the past we have had families that were in Europe. It also allowed the front line to discuss with BSO what they were trialing or report what worked and what didn't. While my referrals and processes are different from the PIECES referral processes, it worked well in addition to the work I was already doing on a regular basis. I'm planning to try to find ways to continue to encourage and these processes to be utilized with the processes I'm doing with the PIECES team to incorporate their input, allow them to gain more insight into who the residents are and how this influences who they are and how they behave at this time. Having both our collaborative efforts presents the unique opportunity to create care plans that include input from BSO, patients, family, and frontline RPN staff.
Thanks, Deb and Jacqueline. So my name's Melissa. I'll start by providing a little bit of background regarding where I work. So I work at Vision. Vision is a 146-bed long-term care home in Sarnia, Ontario. We employ approximately 350 frontline staff members. I started working back at Vision in 2003 as a PSW while I was in school completing my RPN diploma program. It was here at Vision that I became a behavioral supports internal champion. So that was approximately 10 years ago. I first heard about the project from a colleague who was the lead of the project. She reported that we had applied to be a part of a research program and Vision was accepted. When we talked about what the focus of the research project was, she mentioned that it involved PIECES. I had previously had a chance to take the PIECES course and was intrigued as to why and what they would be working on and how it would relate to our BSO program. I requested to be involved in the project and became the other co-lead. I had no experience in any previous research projects. I had no idea what would be expected. So to better understand the implementation, next slide, sorry. So to better understand implementation of the research project, I thought I would provide some context of when we first started it. The project started back in December of 2020. It was during this time that our long-term care home was impacted by the global pandemic. In April 2020, our home was hit very hard by COVID. We had an outbreak on our 2 home units. So during this time, families and loved ones were unable to come in or visit the residents. We lost 10 of our residents to COVID. The first initial week of the outbreak, we had 87 staff members off of work. The spread of COVID and impact experienced was extremely challenging and the most difficult time I had faced in my 20-year long-term care experience. I witnessed firsthand the isolation experienced by our residents. The staff at Vision worked really hard to provide virtual visits to our residents and their loved ones at this time. The perception of long-term care in the media also hit hard during this time and solidified that despite even how difficult things could get, there were always ways we could improve the lives for the resident, and the research opportunity was a great chance. When I initially signed up for the project, I knew it would be challenging to implement a project during the pandemic. At that time, I was the only acting member on the behavioral supports team at my home. I was also learning a new role as a quality improvement coordinator and assisting with MDSRI. My passion over the years was to help others understand and gain insight into dementia and behavior management. So I knew that, and I also knew that behaviors were not improving on their own. And if anything, they were increasing as a result of the pandemic and social isolation. I also recognized the importance and need to be transparent and include family members in care planning strategies around responsive behavior management, which became really challenging during the pandemic. So it really brought forth a need to strengthen the use of virtual care in long-term care. The idea that a research team would be assisting us at Vision to improve some of these processes was a definite win for myself. Next slide. The PIECES research team included myself and another coworker as leads of the project. So we met with the research team initially and other participants virtually over Zoom. The research team included members from Western University, WeRPN, PIECES Canada, and 2 other staff members from another long-term care home titled Copper Terrace. All of the participants were very knowledgeable about research and what it was like to be involved in research projects. I can remember our first meetings and discussions around how we should collect data. Will it be qualitative or quantitative data? Were there any previous studies which involved PIECES? Discussions on approval of ethics, evaluation tools, what research frameworks to use. A lot of it was over my head. I was very honored to be a part of the research and behind the scenes discussions and planning for the project. And the team was always very inclusive, preparing the project to be rolled out from beginning to end. They kind of walked us through it. We met frequently in the beginning. The team created meetings and agendas and minutes to keep us up to date and action plans to keep us on track. As the project evolved over time, we started discussing who would be involved in this project, what is PIECES. Some of the research team was not familiar with what PIECES was, and what the virtual component would be and how it could be offered in long-term care. Conversations began reviewing what the processes in long-term care were. For example, how are we currently engaging with families and residents for care planning? And I can remember thinking at first that I wasn't contributing to the research project, but I began over time to understand my role on the team. And that role was to bring knowledge and expertise regarding long-term care processes and to help facilitate how the project was rolled out successfully at our home at Vision. Next slide, please. So implementing PIECES at Vision began. We recognized that in order for us to implement PIECES, we would need to train some of our registered staff in PIECES. We decided it would be best to train 5 of our RPN staff members, along with myself. I had not taken the new PIECES Canada course, and it was being offered virtually. To understand a family member's perspective, we decided we would recruit 2 family representatives to participate in the initiative as well. We began recruiting 5 RPNs to take the PIECES training. It was challenging recruiting RPNs to be part of the research team, I will admit. The challenges we experienced involved dealing with outbreaks, staff burnout, a shortage of healthcare workers, including RPNs in our long-term care home. The dedicated leadership team supported our frontline registered staff and assisted with covering shifts for team members to be able to participate. At Vision, RPNs are the team leaders of each unit. They really know the residents that they are taking care of and are responsible for communicating important changes to care to residents and families. Having the opportunity to provide education to our RPN leads was invaluable. All of the RPNs were excited at the chance to gain further education. So in selecting the RPNs, we decided we would choose a variety of the RPNs, some being new to the home, some being there for a number of years. The new virtual PIECES training was provided online. The program rolled out a 3-question template and included an updated PIECES resource book for each participant. Each RPN was responsible for completing a homework assignment on a resident exhibiting responsive behaviors using the PIECES framework. The training for PIECES is a 2 full-day education course, and the second day the group would go through the framework and discuss their findings based on their homework assignments. The program is designed for registered staff. It is a client-centered approach that focuses on understanding the resident exhibiting responsive behaviors and coming up with approaches to help manage behaviors. Once the registered staff really understood PIECES and completed the education, the research group wanted to hear from them to gain insight into how we could use and implement this information in our home. We met in a focus group to discuss how they envision this education being implemented at Vision to help manage responsive behaviors. Next slide. Vision's RPN focus group identified 3 major themes. 1, in order to implement PIECES at Vision, we needed to include family when behaviors first occurred. Based on their findings, they really understood that family had a lot of helpful information regarding the residents, past and history, which can lead to better understanding of behaviors. It also supported the need to be transparent with family members. It was highlighted by the team that some of these conversations were very difficult to have and that they needed some support in having those conversations. Second, our frontline staff identified that in order to complete the PIECES 3-question template, they needed time outside of a normal shift working on the home unit to properly assess and connect with family members was too difficult to do in a regular shift. The third one was registered staff also identified and advocated to include the perspective of PSWs and other frontline team members to help better understand why the responsive behaviors were occurring and strategies that were effective at improving responsive behaviors. Based on the information shared at the focus group meeting, we were able to walk through both the current steps that we were currently using in managing responsive behaviors and include the new themes identified. An algorithm was created which assisted us with the implementation of PIECES in our home. We valued all of the information shared regarding the time needed to complete a PIECES assessment on a resident and asked all 5 of the RPNs who had received PIECES training to become part of our BSO team as champions. We later titled this the PIECES Resource Nurse at Vision. This would ultimately lead to 2 of the 5 staff who committed to become our PIECES champions or BSO champions. Next slide. Collectively, our team at Vision discussed the need to document our assessment findings. We discussed ways we could do this. Using the PIECES framework, we created 2 new assessments. The first assessment created was titled the PIECES short form. It was created on paper to promote the use by all frontline staff as suggested by the RPNs. This form would ideally be used by the RPN on the home unit to initiate a team huddle and collect all of those thoughts and discussion points based on PIECES. They would look at the priority concern, contributing factors, social history, and identify any risks. It followed the 3-question template. It would also serve to assist in the referral process for a more in-depth look at managing responsive behaviors by our PIECES resource nurses. A second document was created titled the PIECES long form, and this was created in our point-click care environment. It was a bit more complex and designed for the PIECES resource nurse who had the education to document findings using the PIECES framework. Both of the forms were created with the help and input of PIECES Canada members on the research team. Our administrative staff team committed to scheduling RPN PIECES resource nurses 2 shifts per month each for a total of 4 shifts per month. This would allow for adequate time to complete PIECES assessments and follow up and connect with family members. Again, the goal was to include residents and families in discussions and notify families that their loved one was experiencing responsive behaviors and to gain further insight as to possibly why. We discussed options for virtual care planning with families using both phone and Zoom conferencing, emphasizing the benefits of Zoom. The initial goal was that frontline staff would call families when they use PIECES short form to not only inform them, but again, to gain insight and further information regarding what could be causing the behavior or any approaches that were effective at managing the behaviors. The PIECES resource team would offer follow-up virtual care planning meetings to discuss effective or ineffective approaches to care and strategies that the team members were working on. 2 family members were recruited to the research team to assist in providing the family member perspectives and insight regarding the importance of being included. I feel that virtual care planning would have been better received by family members if it was implemented during the initial stages of the pandemic. By the time we were implementing the virtual conferencing part of the research project, a lot of the restrictions had lessened. Family members were allowed back in the home to see their loved ones. And I feel like it would have been a lot more embraced by some of the family members if we had done it towards the beginning. If a resident's family member declined, we would note the reason. At times it was in relation to it being easier to come in person now that the restrictions were lifted. Some of the family members didn't have a computer or an iPad, or they had limited knowledge on how to use Zoom and the technology. We recognize the need to spend time educating our RPN PIECES as well on how to use the technology in Zoom as a new platform. It included sending out invitations to families, as well as a need to educate families on the new technology. With the creation of this new process, it was imperative that we rolled out education to our frontline staff as well. A plan was created to educate all of our staff. The education was provided at department meetings for registered staff and all frontline staff. The research team was really helpful in creating an education PowerPoint, scripting for staff to use when they had to call families, and information regarding the PIECES framework to further their understanding of what it was. Our partnering long-term care home provided a lot of insight into what worked regarding their implementation phases. Overall, having another long-term care home to discuss ideas was extremely helpful during this journey. We continue to work on sustaining the PIECES program and provide ongoing education regarding the process and how to use virtual care in our home. Part of that sustainability plan for the PIECES research project is to ensure it's embedded in our current policies and responsive behavior management program. Virtual care planning has actually expanded in our home. We offer access to teleconferences and Zoom conferences as options to connect with families virtually for care planning, with family members and residents for admissions, significant change in health conferences, and annual care conferences. We continue to use PIECES trained RPNs or PIECES resource nurses here at Vision to connect with families and staff to help manage responsive behaviors. Our staff are really Excited to see the improvements in residents' behaviors when we work together to discuss the person, their likes, dislikes, and what approaches work or don't work. Staff realize that it takes time to gather and collect the information to better understand the resident, but they also see the benefits and reported that even though it may take time at first, it really pays off in the end, and they actually reduce and see a reduction in responsive behaviors.
So thank you all, Deb, Jackie, and Melissa, for your stories. I really feel that they're authentic and a really a lived process. So part of these research webinars, we've been trying to increase our ability to make them interactive. So I'm going to ask the presenters just some questions, just so that we can send home the key messages we wanted people to take away from this webinar. So I'm going to ask each of you, what was best about your experience? What was the best part of your experience? Deb, do you want to start?
I think what the best part was getting a chance to see how excited and involved my other coworkers were in the project, that the ones that got to have the pieces training that hadn't before, because as a BSO, like, I do get some feedback, but having them involved in this gave them more of an idea of what I was doing and gave them an idea of a way to suggest what is working for them and what isn't working for them on the floor. So it was a chance to get more involved with me and with the family and the residents and try to find solutions and unique opportunities that worked for them, knowing that they were the frontline individuals.
Great, thanks. Melissa?
Yeah, I agree with Deb as well. I also really found that working with the research team, the ability to kind of see it from beginning to end and collaborating, having them help and assist, mentoring us when we had questions. I really thought that that was a great experience. And I didn't know where I fit in the beginning, but as I kind of learned my role and how I could help out the research team, I felt that it was very rewarding. And I was actually extremely happy that I volunteered.
Great. Jackie, what was your best experience?
I'd have to say seeing the impact we were making with our residents and their families by providing personal interventions that have been effective. I found we had a lot of great feedback from families. They felt like we were really digging into the family and reasonings of why there's behaviors like that and actually having solutions to it.
Yeah, that's great. What was one of the facilitators to do that? Like, what would you say facilitated that?
Staff expressing their excitement with the pieces team after we started going. It also assisted in having more involvement from the other pieces trained RPNs. So it helped a lot having more people on board.
Yeah, great. Deb, what would you say facilitated your experience?
I think having the management help me get involved in the process, because I wasn't initially part of the project, and they started explaining to me what was happening and what they had been working on and what was working, and all of the different like, they had showed me where the scripts were and how the team referrals worked, and letting me get a chance to have more of an idea of what was happening and giving me the opportunity to take the time of having one of the nurses who had been trained to actually do the training with me, which was nice because then I had them actually show me their experiences and tell me what worked for them and what didn't. So it was really a personal perspective of somebody who was actually involved in the project the whole way, and it being a frontline staff as one of my co-nurses actually being the one being able to do the training with me.
Yeah, really good. They were able to kind of explain it to you. And then Melissa, what facilitated your experience?
Yeah, I really felt that the frequent meetings that we had with the research team and looking at how we were implementing holistically, really making sure that we were including the family members' perspective, the registered staff's perspective, having those focus groups kind of guiding us to ask the questions so that we really knew why we were implementing this and what our goal was. So I really felt supported by our research team.
That's great. That's great. And of course, always with these projects, you know, there's never a good time, obviously, with hearing your stories. But what was one of the main challenges, or a few of the challenges? Jackie, do you want to start us off? What did you find was kind of the main barrier?
I would say the biggest barrier was the outbreaks. Being short-staffed, it was really hard to get the staff off the floor in order to complete when it would have been the most beneficial at that time. But it
Yeah.
was just too hard to facilitate during an outbreak.
Yeah, it was. It also delayed things, didn't it? We had to defer a few times, and yeah.
Yes.
Yeah. And Deb, what did you see as a barrier being on the research team or being in the project?
I mean, always it's trying to find the time in your busy day to put it and get the staff have the time that they need to get involved with it can be a challenge. Also, sometimes the residents or the family members aren't always on board and they don't always understand what you're trying to do. So it's trying to find a way to communicate and educate them in a way that they would understand what we're doing and how we're doing it. And that can be challenging at times too, because they don't really understand what pieces is, because it is geared towards RPNs. So a lot of them haven't heard about what the pieces is. So that can be a little challenging as well.
Yeah, it really takes every health teaching skill you could come up with. Yeah. And Melissa,
Yeah,
any barriers that you...
Yeah, I agree with Jacqueline and Deb. 100% staffing and the pandemic. The rollout of the virtual care planning to families was also a challenge. And I think because we had deferred some of the items for so long because of the outbreaks that were happening or staffing issues. I know our registered staff were also feeling burnt out at that time. So I think that was also a challenge. They were really excited about the education. And then when they heard that they were going to ask to implement it here, I think it was one other thing that they thought they would have to implement in their daily routine. So when we had that focus group and really listened to them and took it out of what they would normally do in their daily routine, I think that was helpful. But yeah, the staffing and COVID for sure.
Yeah, great. And then just one more question. Kind of what was it like to, working with both of your homes on this team? And kind of like, what was it like to be, like, what would you say the key messages for being on a research team with another home? Melissa, do you want to start?
Sure, yeah. It was kind of nice to feel that you weren't alone throughout the journey. We would experience an outbreak, and it seemed like Copper Terrace would right after, or vice versa. The staffing challenges, the technology piece. So we knew that we weren't alone. We weren't unique. We could bounce ideas and off each other. And if I tried something, maybe Jacqueline would use it, and vice versa. So it was kind of great to walk alongside somebody else. They also knew the processes in long-term care. So it was great to kind of discuss that as well.
Great, thanks. Jackie?
I agree with Melissa. And I also learned that even though our processes they were similar and we had the same goals, they were different processes and they both had great outcomes. Yeah. And then from this research team, I learned that there are more opportunities as an RPN than just kind of working on the floor, which wasn't really something that I thought of beforehand.
Yeah, it really expanded your not only your opportunities, but it really, you start to look around for other chances.
Exactly.
I think your home experienced that too. They had more opportunities to engage in other research. And Deb?
What I do agree with both of them as well. What I enjoyed was looking at the difference. They had different ways that they got to their processes, and they had different scripts and ideas on how to engage the family and how to do the pieces, referrals. So it was nice to be able to look at both of the paperwork that they had been doing and the different ways they had been achieving that, and trying to get a chance to take them both and try to incorporate them as the best way as I can, what works for us going forward. As well as I did really enjoy having the opportunity to learn more about the study, because when I first started, I actually didn't know a lot. I just thought they were getting pieces trained, and then the other staff, you started talking to me a little bit. So it was kind of nice to learn more about what was happening and to be involved, and hopefully get more chance to be involved in further research and try to find better ways to involve a more collaborative care with like everyone involved in long-term care to make it a better experience for residents and families and staff.
Yeah, it really elevated the RPN role, I think, too. So, okay, next slide, please. So this is the presenter's contact information if you wanted to learn more in detail from each and every one of them. So that's their email address. You can reach out to them. And then the next slide. So in conclusion, really, the findings suggest that the RPN-led virtual video conferencing approaches to team-based care planning can be successfully implemented, although with lots of ups and downs in long-term care. It provided increased opportunities for engagement and inclusivity for the RPNs and other long-term care staff, family members, care partners, and older adults living in long-term care. And from the research team's perspective, our next steps are to explore how to effectively embed virtual care planning processes more broadly into policy and procedures of long-term care homes. So we've received a 1-year CIHR research grant to design a toolkit to implement this virtual presence on a broader basis across the province and share across the internet. And we've had one workshop regarding this study, and to hear the stories of the RPNs who were involved was really impressive, and delightful to hear that they just feel more confidence and more proud to be RPNs. So the next slide.
So I just want to give a very special thank you to all of our speakers here today, Jacqueline, Deb, Melissa, and Nancy, for bringing us this information about your experiences as RPN champions in your respective long-term care homes. In this clinical practice implementation to improve team-based care planning and long-term care. Your perspectives on using video remote instrumentation, the PIECES education and the PIECES framework. You describe the impact on long-term care preparedness for future pandemics, how enhancing the caregiver engagement using video was beneficial, and how enhancing the leadership role for RPN supports workforce recruitment, retention, and revitalization. So now we'll open up the chat and the Q&A for questions from the audience.
I see there's a question, Jen, if you could go back 2 slides to the email addresses of our presenters. There we go. Thanks.
There we go. Okay. And then I have a question here in the chat. So one of our attendees would like to know if there's anyone from staffing, financing, and clinical thinking. And then another one, Chantal, is asking, was this research shared with our nursing officer of Canada, Lee Chapman?
So I can start, I think, on that question. Let's go back to, I'm not quite understanding the staffing, finance, clinical thinking, but I can talk about the one, was the research shared? So we have done the data analysis and the write-ups. There's several papers out from this study, and one on patient engagement and one on the impact of virtual care and virtual learning. So we can send those citations to you, and much of what was said today is in the paper about what patients and what residents and their families felt during the process and what staff felt during the process. And I can get you those, but it hasn't been shared directly with Lee Chapman, so that's actually a good idea. And so it's one of the questions is whether we used private care or not. Both of these homes actually are private. One is owned by Apens. Jackie or Deb, is it Apens or Appens?
APANs.
APNs. So that's it's a private company, and Vision is private.
We're not for profit. Yeah, we're not.
Yeah, but you're not for profit. Yeah.
We have a board of directors that govern us.
Yeah, yeah, but this was not done in the community at all. It's all long-term care. Yeah.
So Nancy, I have another question about opportunities to expand this project beyond long-term care.
Yeah, that's a good question. I guess what do you guys think? What do you think it could be done in like rest and retirement homes or actual resident homes?
Yeah, I honestly think it would be a great opportunity. Pieces is a holistic approach to care. I think family members often want to be there if a nurse is assessing a resident out in the community. So sharing that virtually with other family members would involve them, probably streamline that communication process. Same with retirement. I think the needs are changing in retirement homes as well. So I think it would be great even to external behavioral supports organizations. I think that would be, I know they already kind of focus on the pieces framework, so just another enhancement.
Thank you. And then I have a question here about nursing students. Is there opportunity for new nursing students to get involved in this research or similar research?
Yeah, I actually, it's always really good to have the frontline people involved in the research teams. That's what we found, because we get incredibly better contextual information when the actual RPNs are present. And the students generally come along if they're that RPN student. So there's nothing barring students from being engaged in this. So yeah, I would think if it's going on in your home or your placement.
Also, I would suggest if you're a student and you're interested in research, you could go to one of your professors at your college and ask if there are any research studies and how you could be part of a research team.
Just to add on to that, I do believe like we do have students come into the home often. And I believe when we were doing some of the referrals, the nurses that were pieces trained had students following them, and they did go along and complete the referrals as well. So they got that experience as well.
Do you have any advice for nursing students or nurses interested to take pieces training?
I mean, if you get the opportunity and you can do it, I would say to do it because it is a really good course. It does help you prioritize on what is like a high, like what the different things that you need to look at when you're trying to care for your resident and what the priorities are and what can wait and what you need to focus on right away. So it is a very good program.
Thank you, Deb. We have, so I'm just looking at the chat here. Chantel, can you let us know a little bit more about what you'd like to know about the retirement? And Chantel's suggesting that there might be an opportunity to speak with the educational boards about including pieces in their training as they do with other programs, such as the gentle persuasive approaches.
Yeah, I think pieces, because it's a 2-day training, it has a bit more cost to it. So, but now that it's virtual like that, it was I think it becomes more affordable because they changed the format and the content a little bit to make it shorter, and so it may be more affordable now. And then I think I talked to the BSO regional specialists in my area, and they offer pieces training as well. So if you're looking for places to find where to get pieces trained, your regional BSO office or your BSO lead in, I think they have BSO leads in every long-term care home. So that person would be knowledgeable.
Maybe if it's not available at your organization, I mean, there's usually posts, like if you search it on the internet to look at what pieces training in the different avenues of becoming pieces trained.
Mm.
Okay, and then coming to our.
So it looks like the same availability isn't in private homes, like private rest homes, or not so much long-term care. Every long-term care, regardless of ownership, should have BSO, but in rest homes, I don't think it says prevalent.
And I think rest homes as well. So I don't know if they always have a registered staff member in a rest home. I think as the behaviors increase for a resident, they would be put on the list for crisis placement for long-term care. So that could be one of the barriers because they're gearing it up more so for long-term care.
I think they put in referrals to the external BSO team for some of the like rest home areas because they don't actually have like an internal BSO team. So then they'd have to go and wait for the external team to come and help them out with the behavior. So I'm not sure how much people or how much they would have a set aside for education exactly, because the pieces program is like specifically for RPNs. So I don't know if it would, if the people that aren't RPN, they tend to do more U first, which is like a 1-day program. So that might be something that you might be able to present. If you're not an RPN, then they might be able to look into maybe that as an option.
So this question might be for Nancy then. When a researcher is looking at developing a new study design and having a research purpose, could you give a little bit of information about what goes into selecting the setting of the research and some of the work that goes behind the scenes, and maybe why research projects like this one focuses in one sector and not cross-sectored?
Yeah, and that's a really good question. What basically we look or are told about calls for proposals, and it's whatever the funding body kind of has as their priorities for the year or even at that moment in time. And so this study was funded for long-term care because of a really early report that was provided from the first part of the pandemic, because they wanted to impact right away, make changes right away. And so they said they did this report really quickly. They found these 6 promising practices, and then you applied with partner long-term care homes to try an intervention. And at the time, we were working with a researcher who had been doing a lot of intervention about pieces. And pieces hadn't really surfaced in Ontario for a while. It started in Ontario, but it hadn't been surfaced too much in the recent past. So the recommendation was to try and bring pieces in to curtail the amount of the antipsychotic drugs that were being offered, and the behaviors that were resulting from the COVID isolation issues. So it was targeted on COVID and long-term care because of the tragedies that had happened in long-term care early in the pandemic, and the funder kind of really captured at the time what they wanted done. Other times calls come out that are more generic, but still sector specific. So it just depends on what the call priorities are or what the goals of the money is supposed to assess.
Thank you so much, Nancy. That's very helpful. I know sometimes it's hard to see what goes behind the scenes. And as Deb, Melissa, and Jacqueline were talking about what led them to becoming engaged with this particular study and how their role evolved throughout and how their understanding of research, this helps to kind of put everything back into that context, looking at the aim and purpose of this study. So just looking if there are no further questions, I'd like to have Nancy, our research consultant, tell you about some upcoming research activities.
And I see that there's some really good conversation going on in the chat room, so I hope we can capture that in some way. I don't know how we do that with Zoom, but maybe we can answer after, at a later time. So can you just forward the slide a little bit to, yeah. Oh, I didn't put anything on there. Okay. So thank you all from my perspective too, to the presenters, really to explain your experiences, and to Jen for hosting our webinar, and looking after all our logistics with the questions and conversation and everything. So I'm just going to share quickly what's happening in the research. First of all, I'd like to welcome Jen Calvert, who's now working as a research coordinator for WeRPN Research Department. Her experience as an RPN and now a PhD student has added immense value to the implementation of our research strategic plan, and she continues to provide valuable leadership and insight into our next phases. So we're pretty excited about Jen joining us, so thank you. Secondly, we are beginning the workshops for the co-design of the Virtual Care Planning Information Toolkit. So I said that earlier, and we're really gaining valuable information from those frontline RPNs that had been involved in this project. And that is a $20,000 grant from Healthcare Excellence Canada and partners. So we're studying how we can get this piece's information out via website, infographics, or resources. Another thing we're doing right now is we're completing the analysis phase of a Social Sciences and Humanities Research Council of Canada grant titled Resiliency on the Job as a Home Care Nurse. So that one is in the home care sector. Experiences of registered practical nurses to inform recruitment, retention, and revitalization of this workforce. So we're planning for a validation forum sometime after April 2024, and manuscript development and knowledge mobilization is underway with that information. Additional research partnerships are being pursued around healthcare workforce recruitment and retention, and we're looking at being involved in the study with Toronto Metropolitan University, Western University, and St. Elizabeth Health Services between now and the spring. 3 studies are requesting RPN participation. So if you see that in your Pulse newsletter or your research newsletter, we're looking for participants around employment trajectory of Philippine-educated and Filipino-Canadian nurses in Ontario. We're looking for rehabilitation nurses' perspective on the geriatric nursing practice environment and the quality of older people's care in Ontario rehabilitation hospitals. And we'll soon be looking for participants who can help with their opinions in optimizing the role of the RPN in the operating room, exploring facilitators and barriers to facilitate career opportunities. So if these studies are of interest to you and you fit the eligibility requirements, please don't hesitate to add your voice. We just awarded 4 23-24 WeRPN funded academic research proposals and 3 RPN research fellowship proposals for a 1-year period wrapping up in June 2024. And further fellowship opportunities will be available in 24-25, and the call goes out for them in November of 23. So think about applying for an exciting learning opportunity. We're also involved in research around the Bridging Educational Grants in Nursing Research, Bridging Educational Grants in Nursing program. And we've had a number of studies about that program. And then finally, we appreciate you continuing to be the voice of RPNs in research, and that's how we grow the evidence. So if you are interested in any of the studies that we're doing, please don't hesitate to reach out to Jen or myself or Annette. And as Jen is developing a roster of RPNs who are interested and would like to sit on research teams. So back to you, Jen.
Thank you so much, Nancy. So we would like to thank you all for joining us this evening for the WeRPN quarterly research webinar titled Experiences of RPN Champions in Virtual Team Care Planning and Long-Term Care Using Pieces, a Research Project, and hearing how the experiences of 3 RPNs who serve or served as RPN champions in the research study enhance the study design, implementation of a novel clinical practice change, and the findings. So as you are aware, RPNs are knowledge professionals who must maintain clinical competence and advocate for the implementation and use of evidence. Competent RPNs are expected to advocate for and use knowledge, critical thinking, critical inquiry, and research to build an evidence-informed practice and integrate relevant evidence into clinical practice, ethical practice, legal practice, foundations of practice, and collaborative practice in conjunction with underlying assumptions, such as advocating for implementation and the use of evidence-informed clinical practice. Therefore, evidence to improve healthcare and RPN practice needs to be built with RPNs and informed by RPNs. So our engagement as RPNs in various research activities will help to increase the accurate representation of the Ontario RPN workforce and strengthen the evidence that shapes health policy and practices to promote improved care. These 3 RPN champions have demonstrated truly competent leadership that has encouraged and supported their colleagues to implement a significant clinical practice change throughout a very trying time during COVID. Their perseverance is inspirational and admirable. This leads us to the end of the WeResearch webinar, and we thank you for joining us this evening. Our emails are here if you wanted to take a quick screenshot of that, and we wish you all a great evening.